I am a urologist. I have been practicing for over 2 decades, and there is something I see in my clinic that still stops me every time. Not because it is rare, but because of how consistently men ignore it until it is too late. When a man tells me his erections have changed in the last year, harder to get, shorter, less firm, less spontaneous, the first thing I reach for is not a prescription. It is a cardiology referral form. That is not an exaggeration. That is not me being overly cautious. That is me following the evidence that has reshaped how every serious urologist in this field thinks about erectile changes in men over 45. And today, I am going to explain exactly why. Because your doctor may not have had the 10 minutes it takes to connect these two things in the office. If you are watching this and you have noticed any shift in your erectile function over the past 12 months, not catastrophic failure, just a change, stay with me until the end. What I am about to explain may be the most important clinical information you receive this year. I see patients every week who were handed a blue pill and sent home without anyone asking the question, why did this start happening now? Most men in their 50s and 60s who come through my door with erectile complaints have never had a thorough cardiovascular workup. They were evaluated for testosterone. They were told their levels were normal, and the conversation ended there. The real mechanism, the one that connects what is happening in their bedroom to what is happening in their arteries, was never explained. By the end of this video, you will understand it better than most men who have already been through 3 doctor's visits. Now, before I get into the mechanism, I want you to understand one thing clearly. The information I am about to give you does not replace an in-person evaluation. It is meant to give you the vocabulary to ask better questions when you sit across from your physician. That is the purpose of what I do here. Let me explain what is actually happening inside the body when erectile function begins to change and why this is so directly tied to the heart. The penis, from a vascular standpoint, is not a special organ. It is a hydraulic system. An erection happens when blood flows into 2 cylindrical chambers, the corpora cavernosa, and stays there long enough, under enough pressure, to produce and maintain firmness. The critical word in that sentence is flow, and flow is entirely dependent on the health of the inner lining of your blood vessels, a single layer of cells called the endothelium. The endothelium is not passive. It produces a molecule called nitric oxide, a natural vasodilator, meaning it signals the smooth muscle in vessel walls to relax and allow blood through. When the endothelium is healthy, the signal is strong. When it is damaged by chronic inflammation, oxidative stress, metabolic dysfunction, high glucose, years of elevated blood pressure, the signal becomes weak. Vessels stop dilating the way they should. Blood flow becomes restricted. Here is the part that most men never hear. The penile arteries are among the smallest arteries in the body. They measure roughly 1 to 2 millimeters in diameter. The coronary arteries that feed the heart are 3 to 4 millimeters. The carotid arteries in your neck are several times larger still. What does that mean clinically? It means that endothelial dysfunction, the deterioration of that inner lining I just described, shows up in the smallest vessels first. The penile arteries are affected years before the coronary arteries reach the same level of damage. Researchers at Johns Hopkins studied this relationship extensively and documented what is now sometimes called the artery size hypothesis, the observation that erectile dysfunction often precedes cardiovascular events by 3 to 5 years, not months, years. The penis is, in this sense, a cardiovascular early warning system. The change you are noticing is not primarily a local problem. It is a systemic vascular signal presenting itself in the most sensitive location first. When I explain this to patients, the reaction is almost always the same. They were never told. They went in for a routine checkup, mentioned some difficulty in passing, and were offered a medication that addresses the symptom, the constricted vessel in the moment, without any investigation into what is causing the constriction in the first place. Phosphodiesterase inhibitors, the class of drugs most commonly prescribed for erectile dysfunction, work by prolonging the effect of nitric oxide that is already present. But if nitric oxide production is declining because the endothelium itself is deteriorating, the drug is compensating for a problem that is getting worse, not better. It is the equivalent of turning up the volume on a radio signal that is getting weaker at the source. At some point, turning it up is not enough. The most common mistake I see men make is treating an erectile change as an isolated, age related event, something to manage rather than something to investigate. That framing costs years. The man who comes to me at 62 saying, I've been dealing with this for 6 or 7 years, is the man I am most worried about. Not because of his sexual function, but because of what those 6 or 7 years of progressive endothelial dysfunction may have allowed to accumulate silently in his coronary vessels. Before I go into the practical guidelines, what you can actually do starting this week, I need to stop and tell you something I did not expect to be saying 5 years ago. And I am mentioning it now before the guidelines because if I give you only the lifestyle information without this context, I am giving you half a protocol and calling it complete. For most of my career, I worked exclusively with diet modification, exercise prescriptions, smoking cessation, blood pressure management, and when appropriate, medication. That was the protocol. I was deeply skeptical of supplementation. Not in a dismissive way, but in the way any clinician trained on controlled trials becomes skeptical of anything that has not been through rigorous phase 3 evaluation. If a patient asked me about a supplement, my default answer was, there is not enough evidence, and the evidence we do have tends not to survive scrutiny. What changed my position was not a single study. It was a pattern I kept observing in a specific subgroup of my patients, men between the ages of 57 and 68 who were doing everything correctly: consistent aerobic exercise, Mediterranean leaning diet, healthy weight, no smoking. And they were still plateauing, not failing to improve, but improving more slowly than the physiological literature suggested they should. The endothelial responsiveness was not recovering at the rate their compliance warranted. I started looking into whether there were formulations with peer-reviewed mechanistic support for endothelial function specifically, not formulations marketed for sexual performance, but compounds studied at the level of vascular biology. What I found that I was not expecting to find was that two naturally occurring compounds had a documented mechanism that directly addressed what I was seeing in that subgroup. The first is icarin, the active flavonoid extracted from epimedium. Icarin is a natural inhibitor of phosphodiesterase type 5, the same enzyme that synthetic medications target. The difference is the pharmacokinetic profile. Icarin works more gradually, without the acute hemodynamic shifts that make synthetic PDE5 inhibitors inappropriate for certain patients on cardiac medications. For men whose endothelial capacity is declining, not absent, the gradual preservation of nitric oxide signaling matters. It is not a replacement for synthetic medication when that is clinically indicated. It is a meaningful mechanism for the earlier stage, the stage where the change is beginning but has not become severe. The second is alpha lipoic acid, an antioxidant with specific affinity for vascular tissue. The endothelial damage I described earlier is largely driven by oxidative stress, the accumulation of reactive oxygen species that degrade nitric oxide before it can reach the smooth muscle it is meant to signal. Alpha lipoic acid functions as a direct scavenger of those reactive species inside vessel walls, reducing the oxidative environment that is disrupting endothelial signaling. Several trials published in journals focused on vascular medicine have documented measurable improvements in endothelial function markers in men supplementing with therapeutic doses. I began including a formulation combining these two compounds, along with piperine for bioavailability, which increases absorption of active compounds by roughly 20%, in the protocols I recommend to patients in that plateau group. In men between 57 and 65 who had already optimized their lifestyle behaviors, I began seeing a more consistent recovery of erectile responsiveness within 4 to 6 weeks. Not in every patient, but consistently enough and in enough patients that I have continued recommending it. This is not a medication. It does not carry the mechanism of a drug. It is nutritional support with a documented biological rationale for the specific problem we are discussing: endothelial function in the context of age-related vascular change. I verified the composition and purity documentation before recommending it. I do not include anything in a patient protocol without checking what is actually in it. The link to what I recommend is in the description below if you want to review the composition at your own pace. Now, the guidelines you can implement starting today. The first is one that almost no one connects to vascular health directly: the elimination of daily sitting blocks exceeding 90 minutes. I am not talking about sedentary lifestyle in the general sense. Most men know that message. I am talking about the specific vascular consequence of prolonged, uninterrupted sitting. Research out of Indiana University demonstrated that 3 hours of continuous sitting reduces blood flow in the femoral artery, the main conduit to the legs and pelvic region, by more than 50%. 50%. And the key finding was that the flow reduction was not linear. It dropped sharply within the first 90 minutes and continued to compound. 3 5-minute walks distributed across a 3 hour period completely reversed this effect. Not an hour at the gym, 5 minutes, 3 times inside a 3 hour window. For men whose endothelial function is already under stress, this daily microcirculatory insult compounds over months and years in ways that standard cardiovascular metrics will not capture until damage has accumulated. Stand up every 90 minutes. Walk 5 minutes. It takes almost no effort, and the vascular benefit is disproportionate to the time invested. The second guideline involves dietary nitrate. And I want to be specific here because the general advice of eat more vegetables does not capture the mechanism. Dietary nitrate, found in high concentrations in beetroot, arugula, spinach, and celery, follows a pathway distinct from any other nutritional intervention for vascular health. Once consumed, it is converted by oral bacteria into nitrite, which the body then uses as a reserve source of nitric oxide, independent of the endothelial production pathway that is declining. This is clinically significant because it provides a parallel supply route for the molecule that drives vasodilation, bypassing the damaged endothelium. A study published in the Journal of Nutrition found that consistent dietary nitrate consumption measurably improved endothelial function scores over an 8-week period in men with documented vascular risk factors. The practical implication: 2 to 3 servings of nitrate-rich vegetables daily, with attention to oral hygiene that does not destroy the bacteria responsible for the conversion. Antiseptic mouthwashes eliminate them, which is why I ask men who use them daily whether they are getting any vasodilatory benefit from their diet. They are frequently not. Before I continue, I want to ask you something directly. If this is the first time you have heard the connection between erectile changes and endothelial health, if no one in a medical office ever explained this pathway to you, consider subscribing and sharing this video. The information I deliver here is the same conversation I would have in a consultation that takes 30 minutes and costs money most men do not have easy access to. This channel exists to put that conversation where it belongs, available to anyone who needs it. Like this video so the algorithm understands that men over 50 are looking for serious medical information, not entertainment. The third guideline is the one I consider most underestimated in the entire field of men's vascular health: sleep architecture, specifically the proportion of deep, slow-wave sleep a man over 50 actually achieves versus what he believes he is achieving. Here is why this matters for the mechanism we have been discussing. Endothelial repair, the regeneration of the vascular lining I described, occurs primarily during deep sleep. The body uses this window to clear inflammatory mediators, restore antioxidant capacity, and produce the repair signals that allow damaged endothelial cells to recover. A man who sleeps 7 hours but spends most of it in light or fragmented sleep is not getting the repair cycle his vasculature needs. He wakes up believing he rested, while biologically his vessels are not completing their maintenance window. Several large epidemiological studies, including data from the multi-ethnic study of atherosclerosis, have documented that poor sleep quality is an independent predictor of endothelial dysfunction, separate from age, BMI, and blood pressure. The intervention is not simply sleep more. The intervention is sleep hygiene, specifically directed at deep sleep quality, consistent sleep and wake times to anchor circadian rhythm, elimination of alcohol within 4 hours of sleep onset. Alcohol fragments sleep architecture, even when it helps you fall asleep. and reducing core body temperature in the sleeping environment, which is one of the most reliable physiological cues for entering deep sleep stages. A warm bedroom is not a minor inconvenience. It is a physiological cue the body requires to enter the stages where vascular repair actually happens. The fourth guideline involves resistance training, not for muscle mass or aesthetics, but for a specific vascular mechanism. Resistance exercise, when performed at moderate intensity 2 to 3 times per week, triggers the shear stress on vessel walls that is the primary stimulus for nitric oxide release. Shear stress is the mechanical force of blood moving past the endothelial lining. Every time you perform a compound movement, a squat, a row, a deadlift at reasonable load, you generate a wave of elevated shear stress through major vascular beds. Consistently stimulating this pathway maintains the endothelium's sensitivity to flow. It is a use it or lose it biological dynamic. The research here is extensive and comes from the American College of Cardiology, among others. The practical prescription: 2 to 3 sessions per week, large muscle group movements, never pushing to failure, moderate rest intervals. The goal is sustained, repeated vascular stimulation, not peak performance. Men who do only aerobic exercise miss this shear stress pathway entirely. What does the long term picture look like when this signal is ignored? Endothelial dysfunction does not plateau, it progresses. The same inflammatory and oxidative process that is reducing nitric oxide availability in the penile arteries is occurring, at a slower pace because the vessels are larger, in the coronary arteries, in the carotid arteries, in the renal arteries. The timeline between the first measurable erectile change and a cardiovascular event is long enough that most men feel they have time to wait and see. They do not understand that the waiting period is not a period of stability. It is a period of silent accumulation. Atherosclerotic plaque does not cause symptoms until it causes obstruction. The window between dysfunction and event is also the window where intervention works most effectively. What I observe in clinical practice that no study captures is the quality of life compression that happens in men who spend their 60s managing erectile dysfunction and early cardiovascular symptoms simultaneously. Fatigue, exercise intolerance, sleep disruption, medication side effects, without ever understanding these are manifestations of one underlying process. They feel like they are fighting 5 separate problems. They are fighting one problem with 5 faces. The men in my practice who respond best to intervention, who show genuine improvement in endothelial markers and in erectile responsiveness, are those who understood the mechanism early enough to act on it as a systemic process rather than a local complaint. That is the only meaningful clinical variable I have consistently observed, not their age at baseline, not their starting testosterone level, whether they understood what they were dealing with. So let me close with the synthesis you can take from today. Erectile changes are not primarily a sexual health event. They are a vascular health signal, and in men over 45, they deserve the same clinical seriousness as a new onset of chest tightness or an abnormal lipid panel. The mechanism is endothelial dysfunction, a deterioration of the vessel lining that drives nitric oxide production, and it presents in the smallest arteries first, years before it produces symptoms in the coronary circulation. The practical interventions I described, breaking up sitting, maximizing dietary nitrate, protecting sleep architecture, and using resistance training as a vascular stimulus, address this mechanism from different angles and are supported by research from major cardiology and urology institutions. Tell me in the comments, did you know about this connection between vascular health and erectile changes before watching this video? Or was this the first time anyone explained it this way? The body has a window of vascular plasticity, the capacity to respond to intervention and actually regenerate endothelial function. But that window is not fixed. It narrows progressively with age and with the duration of ongoing oxidative stress. The research on endothelial recovery is clear. The earlier the intervention, the greater the measurable improvement in vascular smooth muscle responsiveness. Waiting does not preserve your options, it reduces them. The nutritional support I mentioned earlier, the combination with icariin and alpha lipoic acid, makes clinical sense within a complete protocol, precisely because it addresses the vascular mechanism at the cellular level as a complement to the lifestyle interventions, not a replacement for them. For men in the plateau group I described, it has been the element that closed the gap the guidelines alone could not close. The link is in the description and pinned in the comments. Open it, review the composition, and evaluate it calmly and at your own pace. That is all I ask. The patients in my practice who made the most meaningful recovery were the ones who stopped waiting for the problem to become unmistakable before deciding it was worth addressing. By the time the signal is unmistakable, the vascular process has been running for years. Act on the early signal. That is what it is there for.